Lecture 42, The Social Context of Mental Illness. Traditional forms of psychotherapy tend to treat the individual patient in isolation. But psychologically speaking, as the English poet John Donne put it, no man is an island. Individuals live their lives in the context of other people, and it would be foolish to assume that the social context has no bearing on individual mental patients and the course of mental illness. We've already seen how certain anxiety disorders, such as phobias and obsessive-compulsive disorder, can be acquired through social learning, as well as through direct experience. And also how expressed emotion, how other family members view and behave toward the patient, can influence recovery and relapse in patients with schizophrenia. In addition, many psychotherapists understand that it is not enough to treat the individual patient, precisely because, in some psychologically real sense, it's not just the patient who is ill. And if so, it's a mistake to treat the individual patient as if he or she were the only person that mattered. At the very least, other people have to be enrolled in the treatment process. This is obviously the case with many problems in living, such as marital difficulties and other relationship problems. If a marriage is in trouble, you can't hope to fix it by working on only one partner. Both partners have to be in the therapy together. Many patients are treated in groups in addition to or instead of individual therapy sessions. Group therapy has obvious economic advantages and psychological advantages as well. Patients can learn that other people have problems like theirs and learn how others deal with them. Individual patients can find social support and encouragement for their own efforts to get better, and models for improvement. Some patients' problems are best observed in a group context, and the group provides a safe place where patients can try out new ideas, feelings, and behaviors. Alcoholics Anonymous is an informal setting created and maintained by recovering alcoholics themselves, which provides many of the benefits of group therapy. Among the earliest proponents of group therapy was Salvador Minuchin, a psychiatrist who specialized in the treatment of eating disorders in adolescents. Minuchin argued that mental illness should not be construed as contained within the individual. Rather, family and other social interactions may be responsible for certain forms of mental illness. These family interactions are truly interactional in nature, meaning that the patient plays a role in shaping the environment to which he or she in turn responds. Minuchin's open systems model postulates that the way the family is organized triggers the development and maintenance of the child's symptoms, and that the child's symptoms themselves help maintain that very same family organization. This pathological family organization is defined in terms of several transactional characteristics. Enmeshment, or a high degree of responsiveness to the child. Overprotectiveness. Rigidity that prevents the child from getting better. And a lack of conflict resolution, which prevents families from acknowledging and negotiating various problems. Minuchin and his colleagues devised a form of family therapy intended to identify, challenge, and break down these features of family organization, and to create a family environment in which the child is permitted and encouraged to get well. This means that the whole family has to stop what it is doing and mobilize for treatment. Outcome studies have shown that family therapy is more successful for adolescent eating disorders than traditional individual therapy. So whether with drugs or psychotherapy or both, or individual or group treatment or both, mental illness can be treated with techniques that are based on scientific theories of mind and behavior. And we know from research which treatments are effective, leading to a remission of the acute episode of mental illness, if not an outright cure. But what about instances of mental illness where a cure seems impossible? There are, in fact, lots of such disorders, including the organic brain syndromes. Remember, brain damage is effectively forever. mental retardation, schizophrenia, autism, and some mood and anxiety disorders that have a tendency to come back time and time again. After the acute phase of mental illness, after efforts of treatment have gone as far as they can go, the patient may well move into a chronic phase. Such circumstances call for disease management, chronic disease management, as well as for rehabilitation programs to help patients and others cope with their chronic disability, get out of the institution if they're in one, back to their families and communities, and make an optimal social adjustment despite their illness. The management of irreversible brain damage, mental retardation, chronic schizophrenia or affective disorder, or autism, is no different in principle from the management of any chronic illness, cancer, diabetes, heart disease, or whatever. Chronic disease has to be managed, and the patient has to be helped through rehabilitation programs to make an optimal adjustment to this new situation. In principle, rehabilitation and chronic disease management might take place within the structure known as the mental hospital, a hospital expressly designed for the treatment of acute and chronic mental illness, just like any other hospital that was designed for the treatment of acute and chronic illness. The hospitalization of the mentally ill is a tradition that goes back a long way in Western civilization. Bethlehem Hospital in London was founded in the mid-13th century by the religious order of the Star of Bethlehem, expressly for the treatment of people with mental illness, even though the concept of mental illness hadn't really been established at that point. But these hospitals offered little by way of active treatment. They were focused more on custodial care, and quickly degenerated into places for the warehousing of the mentally ill. Bethlehem Hospital in London became known as Bedlam, and people in London used to pay a fee to be admitted to the hospital so they could see the antics of the patients who were confined there, a little bit like we'd pay to go to a zoo or a circus or a freak show today. Society at that point didn't make a clear distinction between the mentally ill, the mentally retarded, and the criminal. In the aftermath of the French Revolution, Philippe Pinel freed the insane from their chains so that they were no longer treated like common criminals. The movement to reform mental hospitals gained speed in the 19th century. Benjamin Rush, a Quaker physician who signed the Declaration of Independence, encouraged the trustees of the Pennsylvania Hospital in Philadelphia to found a separate establishment for the treatment of the insane. Built on farmland west of the town center, it was a glorious building. I worked in a laboratory here as a graduate student, and the place was a real pleasure to work in, surrounded by lawns and gardens with large parlors, individual bedrooms for the patients, furnished just like anyone else's bedroom might be, lots of sun, lots of heat, lots of ventilation, plumbing. There was a deer park, a flower garden, and eventually even a circular railway that went around the grounds. By the 1860s, even Bedlam, now known as the Royal Bethlehem Hospital, had lost its reputation as a freak show and become something that looks just like any other ordinary hospital of the time. Pennsylvania Hospital and its institute, the Mental Hospital, were privately funded, essentially a Quaker charity, and Bethlehem Hospital in London became a royal charity. But in the later part of the 19th century and the early part of the 20th century, the establishment of hospitals for the treatment of the mentally ill became a state function. Whether state or private, these hospitals were typically structured along the lines of Benjamin Rush's reforms: pleasant surroundings and plenty of open space. Here is Binghamton State Hospital in New York, near where I grew up, situated on a hill overlooking the city in a river valley. It looks like a castle. And here's Napa State Hospital in California, so beautiful they even made a postcard out of it. For all their good intentions and all their sincere efforts, the mental hospital system, by and large, didn't work out very well so far as patient care was concerned. Some of the issues involved in the mental hospital system were vividly illustrated by David Rosenhan and his colleagues in the 1970s. They sought and gained admission to a number of different mental hospitals, public and private, by falsely reporting some symptoms commonly associated with mental illness. During the admission interview, all the pseudo-patients, that's what they called themselves, told the truth about themselves except for two matters. First, they didn't reveal that they were academic researchers or that they worked in an academic organization. And second, they claimed to be experiencing auditory hallucinations, in which voices spoke such words as empty, hollow, and thud. Immediately after admission, the pseudo-patients ceased their simulation and behaved normally in every way. Other patients on the ward frequently noticed the change, but by and large the professional staff did not. Most of the pseudo-patients received a diagnosis of schizophrenia, and their behavior was interpreted in terms of that diagnosis. For example, all the pseudo-patients kept journals of their experiences. In the chart of one pseudo-patient, this was described as, "Patient engages in writing behavior," although if the staff had bothered to read what the patient was writing, his deception would have been uncovered immediately. The pseudo-patients were given mostly custodial care, including medications of various sorts, averaging 14 capsules per day. They tongued these pills and then disposed of them when they could do so unobserved. The pseudo-patients stayed in the hospital an average of 19 days, at which time most were discharged with a diagnosis of schizophrenia in remission. That Rosenhan and his collaborators were admitted to mental hospitals is unremarkable. Anyone who reports auditory hallucinations deserves some further investigation. But after their admission, the treatment of the pseudo-patients can only be described as gross negligence. There was little or no investigation of the presenting complaints that brought them to the hospital in the first place. And the clinical staff failed to notice that their symptoms had remitted. There was little or no active attempt at cure or rehabilitation, or apparently any consideration given to the possibility of active treatment. Although the pseudo-patient study is often cited as an example of the effects of the medical model in psychiatry, it would be more accurate to say that the problems encountered by Rosenhan and the other pseudo-patients occurred precisely because the clinicians failed to adhere to the medical model. If the psychiatrists and others on the staff had acted in accordance with the medical model, they would have discovered much sooner that the patient's symptoms had disappeared. They would have been much more observant of their behavior, and they would not have been so quick to dispense medication to patients who did not really need it. Even before the Rosenhan pseudo-patient study was published, the problems affecting many state hospitals, and, for that matter, private mental hospitals too, were increasingly appreciated, leading to deinstitutionalization of mental patients, getting mental patients out of the mental hospital system and back into the community. The sources of the deinstitutionalization movement were varied. One was the beginning pharmaceutical revolution in psychiatry. The advent of drugs, especially the antipsychotic drugs for treatment of schizophrenia, and the first generation of antidepressive agents, afforded considerable control and relief of patients' symptoms. There was also an anti-psychiatry movement blooming, beginning in the 1950s and the 1960s, a critique of psychiatry partly from the Marxist left, but also from the libertarian right, and, for that matter, the apolitical counterculture. Psychiatrists like Thomas Szasz argued that mental illness was a myth. Sociologists like T.J. Sheff asserted that mental patients were simply playing a role, in effect pretending to be mentally ill, playing the role of a mentally ill person in order to negotiate their interpersonal relationships. And other psychiatrists, like R.D. Laing, argued that schizophrenia actually represented a higher form of consciousness. And there were other arguments like that as well, all of which led to the conclusion that mental patients didn't belong in mental hospitals. There was also a burgeoning disability rights movement claiming that mental patients, like everybody else, had a right to the least restrictive conditions of living, and if mental patients were really sick, then they deserved treatment, which they weren't getting in the mental hospitals, and so they ought to be discharged from them. And then, finally, there was the sheer economics of the mental hospital system, especially the state mental hospital system, and the idea that, especially with the advent of medications, mental illness could be more effectively and more economically treated outside the mental hospital system, back in the community. So first with mental illness, schizophrenia, affective disorders, and other chronic mental illnesses, and then later with mental retardation, patients in state mental hospitals, and some private mental hospitals as well, were discharged back into the community, ostensibly to receive treatment in the community. Most state mental hospitals now are just shells of their former selves, with very few patients, chiefly the sickest or the most dangerous, and very few staff. Unfortunately, the deinstitutionalization movement didn't really succeed in getting mental patients better treatment, less expensively, in the community. In the first place, many patients were discharged prematurely. They simply weren't prepared to live lives outside the confines of a mental hospital, even if they were living in group homes and halfway houses. There was also a lack of financing. The money simply didn't follow the mental patients out of the hospitals and into the community. Money saved by shuttering the mental hospitals wasn't sent over to community mental health services, but was used for other government purposes. And finally, there was a lack of community support for treatment of mental illness in the community. You've heard the phrase, "not in my backyard." And nobody wanted a halfway house for mental patients or a group home for mentally retarded people in their neighborhoods. The result, frankly, was that a lot of mentally ill people ended up on the streets. It's been estimated that 1/3 to 1/2 of all homeless individuals in America have a diagnosis of mental illness. And frankly, it's not at all clear that deinstitutionalization has been a great benefit for them, which is too bad, because it didn't have to be that way. With adequate preparation before discharge and adequate support afterwards, it's very clear that a large proportion of the chronically mentally ill could be helped to achieve fairly normal lives. Even in the cases of the organic brain syndromes, developmental disorders like mental retardation or autism, and psychoses like schizophrenia or affective disorder, certain behavioral treatments, such as token economies, can employ the principles of instrumental or operant conditioning to help patients to acquire new, more adaptive behaviors, even individuals with actual or presumed brain pathology. In token economies, patients receive tokens such as poker chips or monopoly money contingent on their performance of certain actions, such as cleaning their living area or dressing themselves. These tokens may then be exchanged for goods at the hospital canteen or for other privileges such as day trips. In the language of instrumental conditioning, the tokens are secondary reinforcers. Perhaps as much as medication, these training procedures are known to help chronic mental patients return to their families and live in their communities by allowing them to acquire the repertoire of behaviors that they need to live outside the confines of the mental hospital. Whether inside the mental hospital or outside in the community, one of the serious problems with getting the mentally ill effective treatment is that there is a stigma that's attached to mental illness. Irving Goffman, a sociologist, defined stigma as an attribute of a person that is deeply discrediting. An attribute, the stigma, that turns a whole person into a tainted, discounted one. The stigma is socially discrediting, leading an individual to be viewed by others as undesirable and to be rejected. Now, mental illness isn't the only source of stigma. There are lots of different ways that people can be stigmatized. Sometimes they suffer from deformities in physical appearance, such as leprosy, or a clubfoot, or cleft lip. Sometimes the stigma comes from being a member of an ethnic minority group, being black in a white majority society, being Muslim after the terrorist attacks of September 11th, 2001. But having a mental disorder and having that known to other people, having your diagnosis known to others, is another source of stigma. Alcoholism and drug addiction are also sources of stigma. The difference between a physical stigma and a mental stigma, however, is that the mental stigmata, that's the plural of stigma, the mental stigmata are not immediately apparent to other people. Stigmata always serve to discredit the individual, but in the case of psychological stigma, like a diagnosis of mental illness, the person isn't discredited until the fact of that stigma becomes publicly known. In the meantime, he is what Goffman termed discreditable, that is, a person who is vulnerable to being discredited, either when he or she reveals the stigma by saying that he's mentally ill, or when somebody else finds out about it. If a person can successfully conceal his stigma, that's a situation that Goffman called passing. In the same way that light-skinned African Americans can sometimes pass for white, people with mental illness can sometimes pass for normal. But once the stigma is revealed, the individual is discredited in the eyes of others, and perhaps in his or her own eyes as well. Edward Jones and his colleagues expanded on Goffman's conception of stigma by describing 6 different dimensions of stigmatization. The first dimension is the extent to which others can see the stigma. External stigmata, like a physical deformity, can't be easily concealed. But a psychological stigma, like a diagnosis of mental illness, might be more easily concealed, in which case the person can pass for normal for a while. The second dimension is what Jones and his colleagues called the course of the mark, referring to the extent to which stigma becomes more apparent over time. A mentally ill person might be able to pass for a while, but the more time that he spends with people, the more likely it is that he's going to reveal his stigma through his behavior, whether intentionally or unintentionally. The third dimension is disruptiveness, which has to do with the extent to which the stigma can impair the individual's social interactions. The fourth dimension, aesthetics, has to do with other people's reaction to the stigma. And the fifth dimension is the origin of the stigma. Is it congenital, present at birth, or is it acquired? Is it acquired accidentally, or was it acquired deliberately, or as a result of misbehavior? And the final dimension is one of peril, which has to do with the danger, or at least the apparent danger, that the stigma poses to other people. Another analysis of stigma, with particular reference to mental illness, was presented by Link and Phelan. Their first component is what they call the social selection process, in which people identify and label differences among people that are important to them. They argue that most people with a medical diagnosis aren't labeled as different, though some are, and this kind of social selection and categorization occurs especially in the case of mental illness. If people know you've been diagnosed with schizophrenia, that makes a difference to them in a way that knowing you've been diagnosed with high blood pressure just doesn't. The second component is a process of stereotyping, in which the person's label is linked to a whole list of undesirable characteristics. If I tell you I've got high blood pressure, you don't think too much about it. But if I tell you I've got schizophrenia, that's when the stereotype gets invoked. I'm crazy. I shouldn't be around children. I can't be trusted with a job. I might be violent. Whatever. The third component in the stigmatization process is a distinction between us, those who don't have the stigma, and them, those who do. Link and Phelan argued that the labeling process that goes on during the social selection process inevitably separates the stigmatized group from others. This separation between the stigmatized group and the non-stigmatized group inevitably leads to the fourth component, which is discrimination and loss of status. This is the discrediting that Goffman talked about. If people are set apart by virtue of a label, and that label carries with it the implication that they possess certain undesirable characteristics, then we're going to discredit them, devalue them, exclude them, and reject them. This discrimination can take a number of forms, only some of which are direct, where, for example, a patient discloses a history of schizophrenia on a job application and then doesn't get the job because of that. But there can also be structural discrimination, discrimination that's built into the structure of society. When the mentally ill are treated in mental hospitals that are set apart from the hospitals where other illnesses are treated, that clearly indicates that mental illness is something special. If outpatient mental health clinics and group homes and halfway houses are located in the undesirable areas of cities, that carries the implication that the people who are getting treatment there are also undesirable. And then there's the discrimination that occurs when the stigmatized people realize that they themselves have been stigmatized, that other people view them as different, that other people devalue them, don't want them around, and view them as less trustworthy, more dangerous, and less competent. They may then begin to incorporate these beliefs into their own self-concepts and begin to behave in a manner that confirms the implications of the stigma to begin with. The final component of the stigma of mental illness has to do with the exercise of power. Being a patient of any kind means that you're supposed to do what your doctor tells you to do in order to get well. But by virtue of being a mental patient, you lose some of the psychological power to challenge the doctor's authority, to ask questions, and to consider alternatives to treatment. Another part of the problem has to do with the way we generally think about deviance. First, people can place inordinate emphasis on the statistical and social standards for abnormality, labeling as sick behavior that's simply unusual, or infrequent, or non-conforming. An extreme example of this tendency is the use of psychiatric diagnosis as a means of social control, as in the former Soviet Union, where political dissidents were frequently diagnosed as mentally ill. Schizophrenia was a particularly favorite diagnosis, and incarcerated in mental hospitals simply on the basis of their disagreement with government policies. And frankly, there is also a tendency to embrace the moral rather than the medical model of mental illness, so that the mentally ill are perceived as socially undesirable in a way that most medical patients just aren't. We tend to perceive the mentally ill as somehow bad, immoral, or even evil, and as somehow responsible for their own problems, or at least responsible for their failure to overcome their problems. As a result, people tend to impose a criminal role on mental patients instead of the sick or impaired role, emphasizing restraint and punishment as opposed to cure and rehabilitation. We saw this in the extreme in 18th century France, where the mentally ill were literally chained in their cells. So even if we don't want to punish the mentally ill anymore, there's a tendency for us to want to see them restrained, confined, put someplace else, without having much interest in cure or rehabilitation. A familiar example of this tendency is the stereotypical association of mental illness with violence and criminal behavior. In fact, the mentally ill are no more likely to be violent than anybody else. And then there is that tendency towards NIMBYism, not in my backyard, when it comes to the establishment of halfway houses and other facilities for the community care of the mentally ill. Even more subtle perhaps, but no less damaging, are the effects of stereotyping when it comes to the mentally ill, as well as the dominance of first impressions. Psychiatric diagnoses once made tend to stick, so that the person never really sheds the label of schizophrenic or manic depressive or whatever, never really abandons the sick role. Remember Rosenhan and the other pseudo-patients. They weren't discharged with a diagnosis of cured or no mental illness, they were discharged mostly with a diagnosis of schizophrenia in remission. They had a mental illness, it's gone for now, but they still have it. Once a schizophrenic, always a schizophrenic. Generally, there's a popular refusal to admit the possibility of a good outcome in mental illness, the possibility of a truly successful treatment, whether cure or rehabilitation, which would allow the person to leave the sick role and assume the proper role in his or her society. Another factor that subtly keeps the mentally ill sick is the self-fulfilling prophecy, which we discussed earlier in the lectures on personality and social interaction. Almost inevitably, the diagnosis of mental illness creates expectations concerning the patient. These expectations can lead to behavior on the part of other people that will in turn elicit abnormal rather than normal behavior from the patient. And even the patient's normal behavior, or behavior that's ambiguous, will be interpreted by other people as somehow abnormal. And in either case, whether by virtue of behavioral confirmation processes or perceptual confirmation processes, the patient's behavior is going to be taken as confirming the diagnosis of mental illness. And then finally, such a process can lead patients to define themselves, not just as ill, but as incurably ill, diminishing their motivation for therapeutic change. It can also lead those who care for mental patients to substitute custodial care and simple medication for active treatment that might return patients to their normal roles in society. If there are few or no attempts at cure, few or no attempts at rehabilitation for chronic mental illness, we can virtually guarantee that mental patients will never get well. So far, we've been talking about ordinary people on the street and how they respond to people who are mentally ill or thought to be mentally ill. But some of these same issues crop up in government policy. It was only in 1999 that the federal government began a serious policy of taking mental health seriously, with the very first White House Conference on Mental Health and the very first Surgeon General's report on mental health. The Surgeon General pointed out, first, that mental health is a fundamental part of health in general, that we need healthy minds as well as healthy bodies. And he also underscored the notion that mental health disorders are real health conditions. Now, partly what the Surgeon General meant was that many mental health disorders have a biological basis. But whether they're organic or functional, mental illnesses have serious consequences both for the patient and for society, and they need to be taken seriously by healthcare professionals. And partly to address the Woody Allen bugaboo and any lingering suspicions held over from the Eysenck study of the early 1950s, the Surgeon General pointed out that we do have mental health treatments that work. Some of them are medications, some of them are various forms of psychotherapy, but whatever form they take, there are effective treatments for mental illness, and that for most mental illnesses, there's a wide variety of effective strategies for treatment available. The White House Conference and the Surgeon General's report went a long way towards bringing mental health into the mainstream of healthcare. Mental health was no longer to be set apart from the rest of the healthcare system, the way mental hospitals used to be set apart from other hospitals. Here's what the Surgeon General had in mind in speaking of mental health as fundamental to health, and mental health disorders as real health conditions with real consequences. Health economists have developed a measure called disability-adjusted life years, which refers to the loss of life expectancy associated with various medical conditions. And it turns out that mental health conditions like schizophrenia and affective disorder, ranked second in terms of disability-adjusted life years lost due to illness. First rank fell to cardiovascular disease, heart disease, things like that. But mental health problems outrank cancer malignancies. Far more years of life expectancy are lost due to mental health problems than to alcohol or drug abuse or infectious disease. That's what's meant by mental illnesses being real illnesses with real consequences, regardless of whether they have some neurological substrate. Evidence of the recent mainstreaming of mental illness and mental health treatment can be found in the movement towards mental health parity in health insurance. When I took my first job and bought my first health insurance policy, benefits for mental health, substance abuse treatment, and chemical dependency treatment were severely restricted. I had essentially unrestricted coverage for things like cardiovascular disease, cancer, asthma, and the like. If I picked up an infection somewhere, treatment would be paid for, no question. But mental health benefits were severely restricted. If I remember correctly, 30 days of inpatient hospitalization a year and 14 outpatient visits to a psychotherapist. No such restrictions applied to other forms of illness. Mental illness was different. But beginning with the Mental Health Parity Act, adopted by Congress and signed by President Clinton in 1996, that is no longer so much the case. The Parity Act requires that annual and lifetime dollar limits for mental health treatment be the same as those that apply for medical and surgical treatment. And whereas mental health treatment used to be associated with high deductibles and relatively high co-payments, the deductibles and co-payments imposed for mental health services have to be the same as those that apply to medical and surgical services. There isn't complete parity yet. Substance abuse treatment and chemical dependency treatment are typically exempt from these provisions, subject to different limits, different deductibles, and different co-payments. But most mental illnesses now have parity with other health problems, and that's a real step forward in mainstreaming mental illness and mental health, treating mental illness the same way we would treat any other illness. That's all well and good, but this change, this improvement in the status of mental illness and mental health services comes with a cost. And that is that mental health practitioners have to be able to show that their treatments are effective, just like other health practitioners must. No health insurance plan, whether private or public, is going to pay for treatments that don't work, nor should it. And it's a sad fact that many of the professionals who work in the area of mental health have been reluctant to put their treatments to the test, to show that they work as well as they think they do. But that's changing. Psychotherapy outcome research is now part of a broader movement within healthcare towards evidence-based treatments. That is, the use of treatments that research shows are actually effective in treating various mental health disorders. And this is part of a movement toward evidence-based practices in healthcare generally. The medical profession has long cloaked itself with the mantle of science, but the sad fact is that until relatively recently, physicians had relatively few effective treatments available for disease. Mostly, medical treatment was palliative in nature, intended to ameliorate the patient's symptoms and to make the patient comfortable while nature took its course. Or else, physicians simply removed diseased organs and tissues through surgery. Scientific medicine really only began with the microbe hunting of Louis Pasteur and Robert Koch in the 19th century, and successive phases of the pharmaceutical revolution in the 20th century. And it's only relatively recently, remarkably enough, that medical researchers have begun to test practices to determine whether they actually work, which ones work better than others, and which are cost-effective. Evidence-based medicine is epitomized by the clinical trials that new drugs must go through to demonstrate both their efficacy and their safety before they're marketed for the treatment of specific diseases. And something similar is now happening to psychotherapy. For a long time, psychotherapists, including psychiatrists and clinical social workers, as well as clinical psychologists, have operated pretty much in the dark about whether their treatments were actually effective. Many psychotherapists were loath to measure the effects of their treatments quantitatively. They thought it might actually get in the way of therapeutic progress. And frankly, as long as patients were paying out of their own pockets, and as long as the patients were satisfied with their treatment, there was little incentive for psychotherapists to validate their practices scientifically. In the 20th century, as standards for medical practice changed, psychotherapists felt under increasing pressure to demonstrate that their practices, too, really worked. This pressure has increased as responsibility for paying for psychotherapy has shifted to third parties, from patients to employers and health insurance firms. And the movement among psychotherapists towards empirically supported treatments has been extended to everything that clinical psychologists and other psychotherapists do, like making sure that their procedures for diagnosis and assessment are empirically supported as well, and that programs intended to prevent mental illness from occurring to begin with work the way they're supposed to. At present, the standards for evidence-based treatments like psychotherapy are roughly modeled on the clinical trials required before drugs are marketed. In order to qualify as empirically supported, the treatment must yield outcomes that are significantly better than those associated with an adequate control in at least 2 studies, preferably 2 studies conducted by independent research groups. Typically, the control is a group that doesn't receive any treatment at all, such as those who are put on a waiting list. In any case, it's important that the patients are randomly assigned to conditions, treatment versus no treatment. There needs to be some objective evaluation of outcomes, such as an assessment of the patient's symptoms or responses to a checklist of symptoms, something like that. And preferably, as in drug trials, the person who's evaluating the outcome should be blind to the condition to which patients were assigned. That effectively prevents any bias from intruding on the comparison. The criterion for statistical difference is, of course, a statistical criterion. The usual criterion is a probability of less than 0.05 that the difference would occur by chance. The more studies that support the new treatment, the merrier. But it's really important that these studies, at least some of them, be done by different groups of people. Somebody other than the psychologist who invented the treatment ought to be testing to see whether it really works. An ongoing list of psychotherapies that meet current standards for empirically supported treatments is maintained by Division 12, the Division of Clinical Psychology of the American Psychological Association. The standards for empirically supported treatments currently in place are a very good start, but there are various ways in which they could be improved, ratcheted up, to improve the quality of psychotherapeutic practice. For example, we might wish to drop the no treatment control as an appropriate comparison group in favor of some kind of placebo treatment to control for expectations. Or we might want to compare the efficacy of a new treatment to that of whatever the prevailing standard of care is. And should a new treatment simply be comparable to that standard of care, or should it be somehow better than what's already available? These are the same kinds of questions that are raised in drug research. As another example, there's the matter of how to assess the significant difference in treatment outcome between a new treatment and a control group. Right now, the standard is the usual kind of statistical significance. But a statistically significant change in patient status may not be clinically significant in terms of how the patient functions in the ordinary course of everyday living. I think that's right. But there's a problem of exactly what kinds of standards to adopt for assessing clinical significance. And 2 positive studies out of how many? The current standard for empirically supported treatments is modeled on the current standards applied by the Food and Drug Administration to drug studies, which require only 2 positive trials, regardless of how many negative or inconclusive trials there have been, raising the file drawer problem and the issue of selective publication of positive results. It's possible, it could happen, that an investigator gets a negative result and just files it away in a drawer somewhere and keeps trying until he gets a positive result to publish. And finally, but I think this is a really interesting question, there's the question of mechanism. Since the 19th century, medicine has generally abjured mere empirical treatments that are simply known to work, in favor of treatments whose mechanisms of action can be interpreted within the framework of existing knowledge about anatomy and physiology. That's not to say that new treatments can't teach us something new about structure and function. But under ordinary circumstances, we'd expect the way a treatment works to be broadly consistent with what we know about how the mind works and what we know about personality and social behavior and psychological development. If somebody proposes a new treatment and proposes a mechanism for how that treatment works, and that proposed mechanism is broadly inconsistent with what we already know about how the mind works, then that fact alone might be reason to reject it, regardless of how that treatment works empirically. So it would represent a major improvement in the standards for empirically supported treatments if they required not just that the treatment be efficacious, not just that it worked, but that the theory on which the treatment is based be scientifically valid as well. In fact, in the literature on cognitive and behavioral therapies, there is a long tradition of so-called dismantling studies, which employ various kinds of control conditions to determine exactly how a treatment works, exactly what its mechanism is. Now, it has to be said that some practitioners argue against any standards at all, on the grounds that therapists should be free to pick whatever treatment they think is best for the individual patient, and that patients should be free to choose treatments based on their own personal values. But frankly, physicians don't have this freedom. They have to conform their practices to the available evidence. And where evidence is lacking, they have to conform their practices to the prevailing standard of care. And while medical patients get to choose among various treatments according to their values, they only get to choose among treatments that are known to work. If you can treat cancer with radiation, and you can treat cancer with surgery, you get to choose between radiation and surgery. To be honest, sometimes these objections seem like little more than a smokescreen thrown up by professionals who don't want any interference in their practices. Something very similar happened in medicine. But if physicians and surgeons weren't able to escape the demand from third parties like government and insurance agencies that their practices actually worked, there is no reason to think that mental health professionals, clinical psychologists, psychiatrists, clinical social workers, and other psychotherapists will be able to escape either. In the final analysis, clinical psychology owes its professional status, its autonomy from psychiatry, the fact that psychologists don't have to answer to physicians, and its eligibility for insurance payments and other third-party payments to the assumption that its practices rest on a firm scientific foundation. The movement towards empirically supported treatments, towards evidence-based practices, is the best way to show that that's the case.